So you can see how far L5 has slipped forward from the back of L5 and the back side of the sacrum there. So obviously, you know, when we get our athletes, our people with these kind of conditions, you know, we need to really be talking to some spine people, because this is going to change a lot. It's going to do everything from, you know, squatting, deadlift, any kind of lifting types of sports they may not do. I'm not saying your athletes can't compete with this stuff, but yeah, everything has changed. So I have a close-up. So this just shows.
You could just draw right there, Sean.
So where Sean's going to put a little line to see. So that kind of shadow area, that's where your pars fracture is. And so when the posterior element's not attached to the vertebral body, that vertebra will slip forward like that. Okay. I'm not going to go through this chart. You guys can review this. I have quite a few charts that I threw in here. I'm not going to go into, number one, I don't have time, but I really like to kind of throw, some people learn well with charts, and this is a good one. One thing that we do need to understand, simple palpation, know where L4 is at, top of the iliac crest. Can I get my, Adam, where are you at? Is Adam, Sean? When you're trying to find simple palpation, know where L4 is at. You guys can count up and down. Find the iliac crest, go around. So if you go up, you just draw a line, you're going to find L4. If you know where L4 is at, then you're able to kind of go through the rest of the spine. And a lot of times when your athletes are coming off the field, and most of the time when I would work with silent, I'm not really going out on the field, but I'm catching them as they're coming out, they're kind of doing this number, you know, and we're trying to kind of figure out where they're hurt or whatnot. One thing that I highly recommend is learn how to percuss. You have to know how to do it. There's a couple different ways. They teach you to do a lot of put your fingers on, tap. I don't really feel like I can feel much. I like to use my index, my middle finger. I start with light palpation. If you have a fracture, transverse process, spinous process, you dang sure don't want to be whacking on your patient. So start real simple. When they are fractured, sometimes even just subtle palpation, they're going to be kind of buckling. Watch their knees, because they're going to be kind of pulling away from you a little bit. If they can handle that, then go into your percussion. I like to use 2 fingers, 1 finger if I'm in a more sensitive area, and I'll kind of percuss around. If that feels pretty good, athlete's not really jumping, I might put a little pressure, I might do my hand, I might even do light fist. I'm going to feel pretty good. If they can handle all that, they don't have a fracture. There's something I do all the time in the rodeo world. Athlete comes to me first thing, and then I just progress from there. While you have them standing, there we go. This is where you can actually, if your athlete is hurt, sometimes you need to coach them along, because you want to let them know that, hey, let's go ahead and bend forward just a little bit. And they're like, I have pain, I have pain, I have pain, I have pain. All right, we might just think strain. If they go forward, they're not going to get very far. I have a lot of pain that's going into my buttock. We're thinking SI or disc. If you go into extension and they have no pain, you're still thinking disc. If you go into extension, they have pain, we're thinking facet or spondy. Spondy just means bone, so listhesis or lysis or spondylolisthesis, all those fancy words we'll get into in a second. But if you go into extension and you're recreating pain down the legs, we need to be thinking of some type of disruption of the pars or the posterior element. From there, I like to go right into Kemp's. And these are quick things. I'll do this all the time when they're standing. They can have pads on. It doesn't matter. They can be in their uniform. These are just real quick assessments. If you got to take them back, you can, but at least you're trying to figure out, basically, are they broke or are they not? Can I treat? Do they need to sit? What do we need to do? So once I've done a little range of motion, I've done some palpation, percussion, I'm going to go right into Kemp's. If I turn them into Kemp's on the side that they're compressing, if they have a TP fracture, you're going to light them up. You're going to see this motion. They are going to buckle down, or they're going to try to get away from you, one or the two. If they have a lateral disc herniation on that same side, they'll still have a lot of pain. If you have a disc herniation to the right, you should have zero pain going to the left. If you have pain going to the left or to the right, this is your little pearl, you're going to have a central disc herniation. So pain left, pain right, central disc. Because that disc is pushing out and irritating not both nerve roots, but it's getting close enough. I'm walking you through what I do all the time, and I try to be very systematic. And the one thing Sean will tell you is I don't care if they hurt here. I need to know, remember, this is our problem area. This is our problem area. We have to make sure that these areas are safe. We can worry about this in a second. If they're walking to me, I'm going to assume a lot of things, even though I don't like to assume. But those assumptions are good. You can do Kemp's test in a sitting position too, and this is just more for kind of a clinic setting, so I threw both on there. So once again, we talked about facet spondylolysis just means a break in your pars. You'll see this in your young athletes. The vertebral body has not moved forward. It's just separated, broken. It's either a traumatic injury or they're at birth. Spondylolisthesis means that it's actually the vertebral body, not only is it separated, but it's moved forward. So if we understand those two things, two tests that you can do real quick from a standing position, single leg stance test, stork standing, and it's got a picture of stork. And I'm going to keep moving because we've got a few more things. And remember, I've touched on this, facet pain usually does not have neurologic symptoms. That's the main thing I want you to get out of this. Pain can be diffuse. You'll get your athletes and they'll just say, I don't know, I just hurt. Okay. Sean and I were working a rodeo and we had this athlete. I don't know, my hamstring just hurts. Well, which one? Well, both. Okay, and it's like trying to pull teeth out. True radicular symptoms follow a pattern. Your athlete will be able to describe, they'll say, I hurt, and they'll follow a line. When you have radicular symptoms versus referral pain, that's where we're going to get in trouble. Your SI is going to be more referral, not radicular. Even though it will mimic radicular symptoms, it's still referral. It's just another more of the L5S1. Three tests I like to do. So we're suspicious of a nerve root issue. And these are tests that I highly recommend. You know it's safe to lay your athlete down. We can go right into straight leg raise. Now, we always want to do the opposite side first, whether you guys have been taught that or not. The reason is it gives you information. Number one, it's safer, because if the left leg is their issue and I raise the right leg and I create low back pain, I have to be thinking disc herniation, central disc herniation, or some kind of fracture or something weird. If I lift the right leg, I have no symptoms. I can go right into straight leg raise and go right into braggarts. I can go right into Lasag and go right here. Sometimes if you go to 45 degrees and you're not getting leg symptoms, I wouldn't worry about going much more than that. I would go right into Lasag because this is a stronger nerve root traction. And I would go right into that position. You're going to light them up. And if you have a nerve root issue, like I said, in your young athlete, you really need to pose caution on that. Sitting, you can do vectors. So if you sit them down, you can just have them extend their leg. If they get leg symptoms, you can almost bet you're going to have these two tests positive too. If you have all three positive, we have a nerve root issue, which means we either have a fracture or we have a disc. This is something I think is really important. It's called Hoover's test. It's a malingering test. you'll have your athlete raise their legs. Hold that on. And I'm going to have Adam lift the right leg for me. I have very little pressure that he's putting into the left leg. Go ahead and look. When you know your athletes are faking it, is when you don't feel a lot of pressure. And I'm not saying you're faking it. When they're hurt. So if they have a normal spine, they're not going to put a lot of pressure. So Adam doesn't have a lot of disc problems or something going on. He didn't have to push down with that right leg. When they are hurt, when you do this test, so kind of exaggerate. So push down. So they're going to be pushing down, trying to raise this leg up. You know they're hurt. It's called Hoover's test. Look it up. It's really important because you get so many of your athletes, they really don't want to play. They have a back injury. This is a great test to kind of figure out. So if you've done all your nerve root tests, go ahead and throw in Hoover's. I only threw this slide on there just so that we understand the nerve pattern between L3 and L4. So you always want to say the top and the bottom vertebra. In the lumbar spine, the bottom vertebra designates the nerve root. L3, 4, that means L4 nerve root. L4, 5, L5 nerve root. I'm not going to go into detail, but you guys have to know your myotomes. I'll stick around if there's time. I'll show you how I do my straight test. Huge, huge, huge in my exams. I can't emphasize enough, know your myotomes. And if you don't know them, pull Starkey out, copy them, keep them handy, use them as a cheat sheet. You can learn so much. And I'm not asking you to be neuroradiologists, neurosurgeons, trying to diagnose neuropathology, but it's also extremely important because if you know the nerve root that innervates the action, like knee extension, then you know what muscles to rehab. So if you don't think these tests are going to be helpful in your rehab, this is huge right here. So if they have toe extension weakness, you know, that's an L5 nerve. That's everything you got to work on right there. So this is huge. This just kind of demonstrates a little bit. I don't have a lot of time, do I, Sean? If I have time at the end, I'll run through. So we have our athletes. They're going to get hit in the hip. They're going to have hamstring. They're going to fall down. They're going to mimic all kinds of crazy stuff. So let's get to the pelvis here, SI. And remember, the body's going to torque to try to compensate. So if we're taking ankles, something else has to give. If we put a knee brace on, that's fine because the knee's meant to be stable anyways. If we restrict the hip, well, we're going to put pressure on the SI. If we brace the lumbar spine, that's okay. I had a defensive tackle at Travis played in a lumbar brace. He ended up being all state. He played ball at Navy. I thought he was crazy, but he swore it helped him. I wasn't going to argue with him. So these are questions you want to ask. Y'all can look at this. So when your athlete comes in, they have a hamstring injury. You can't tell me that the hamstring doesn't connect to the pelvis. You're going to have SI. You have to work on the SI. Groin injuries. Groin attaches to the pelvis. Your catchers, your football players, they're going to have impingement issues. 3 tests that I like to do real quick. Log roll. If I put them internal rotation and I get pain, I know I have an anterior problem. I do external. It may be a posterior capsule, but here's your little pearl. External rotation of the hip. And you have pain in your SI, then you probably have SI. If you have lumbar pain, you better get x-rays on your athlete because we have an issue. External rotation of the hip is innervated by L4-5. So we know we have an L4-5, so that's a little pearl for you guys to remember. Hip impingement in the rodeo world. We'll probably do this every single rodeo. Hip going into flexion, adduction, internal rotation, they have pain, you have hip. If you externally rotate, going into Patrick's test, figure 4, it's different names for it. And so the third portion of the slide just shows how to test for a posterior capsule. And I kind of showed that real quick. So we definitely have a hip issue. They can't do that. Turn the wrist. There's 4 tests, and there's one on the next slide here. I really like knockless Eli's for SI. Boom, I put buttock to heel to buttock, pain on the same side, SI pain. Go to the opposite side, okay, we might have a contralateral SI. If I do Hibbs test, this is checking for another hip issue. Maybe you did the other test and they weren't, but you got them on their stomach and you noticed there was some pain. They may have an SI or a hip. But something that I really like is this test, and Sean and I have talked a lot about this. This is how you can really differentiate between lumbar and SI. So the hand placement on the lumbar spine, if I go into extension and they have pain, you know it's lumbar. If I stop the SI movement and I get pain in the SI, then I have SI. If I go here and there's no SI pain, and I go here and they have lumbar pain, that's how you differentiate it. Now, can they have both? Of course they can. But that's a real good tool. The next section, Dr. Lindsay, she's going to go into the release me work. Obviously, I do a lot of hands-on. I'm not going to go into any detail. So I'm going to walk you through my treatments in kind of phases, and then I'll stick around for a couple questions. Basically, here's the muscles that I turn around. Yes,